we are continuing the same area of study. So we have finished the anticoagulants. Today we are going to talk about the thrombolytics and antiplatelets. So as you know, in the hemostasis, in that process, um, in the hemostasis process, first of all, the platelet adherence is also important, and it is one of the process, right? So I'm going to share the note. Hope you all can see the screen now, right? So thrombolytics and antiplatelet drugs are the so those two topics, which is complete our section of blood clotting and related diseases. Okay, so thrombolytic and antiplatelet drugs. Previously, in order to make it easy to understand about drugs that affect hemostasis, we divided the process of hemostasis into three. Right? If you can remember, when we study about hemostasis, we divided actually in our body, they don't have these divided, separated things. For us to understand better, for us to make it easier, we divided this recording.
Recording stopped.
Right? So we divided it into three parts. One is blood coagulation, where certain coagulation factors are involved, and then uh, blood fibrin formation will happen. And the next is the platelet plug at the site of injury to block the bleeding. And these generation of fibrin scaffold or the thrombus, making the fibrin around the platelet. And after that, after certain period, when bleeding is stopped, this removal of fibrin, which is known as fibrinolysis. So in the previous chapter, we also discussed coagulation and the available anticoagulants. So in today's lesson, we will talk about platelet adhesion and fibrinolysis, and introduce the role of antiplatelet and fibrinolytic drugs, and also inhibitors of fibrinolysis. Okay. So first we'll look at the role of platelets. Following damage to a blood vessel, the break in the endothelial barrier causes the recruitment of platelets from the circulation. So that means in our blood, in plasma, we have platelets. So whenever there's a damage to the blood vessels, the collagen, I think if you all can remember, we discussed certain components like collagen and other things that is released will attract the platelet to the damaged area, and then they stick to this the wound or the damaged injured place. So they plug together with the vessel endothelial matrix, so which is known as platelet adhesion, and with each other platelet aggregation. So when they stick to the endothelial wall, we call it platelet adhesion. What is it?
Platelet adhesion.
Platelet adhesion. Adhesion meaning it's like sticking to something, right? And then when they stick to each other, now right? So when there is a damage, what's happening? The platelets. Now platelets are in the blood, so they will attract the platelets, and then these platelets go and stick to the endothelial wall. So this is called adhesion, right? Mm, adhesion, right? So when the platelets get together, if they get together, so each other, they have to stick to each other. So that is known as aggregation. So aggregation is a general, and adhesion is also a general English term. Aggregate means like they get together kind of thing. So these two processes, adhesion and aggregation, will happen. Right? Is that clear? Is it clear now?
Yes, Miss.
Okay. So platelet adhesion leads to the activation of platelets following stimulation by the following substances. Platelet adhesion leads to the activation of platelets following stimulation by the following substance and interact with surface receptors of platelets. One is substances formed outside the platelets but interacts with platelet membrane receptors like catecholamines, collagen, thrombin, prostacyclin, glycoprotein 2A, 2B, 2B and 3A. So these kind of compounds, substances which are formed outside the platelets, right? But they can interact with the platelet receptors, membranes, membrane receptors, and activate the platelets. And there are certain other things, agents generated within the platelets and interact with membrane receptors like ADP, prostaglandin D2, prostaglandin E2, and serotonin. And there is another category, agents generated internal to the platelet and interact within the platelet, not with the membrane receptors like prostaglandin endoperoxides, tissue plasminogen activators, thromboxane A2, and CAM, right? Um, so it's like this. Um, so it's like um, right? Um, so it's like now we said there is a damage. This is the damaged area. Um, and then there are platelets. Platelets are there, right? So if you take a platelet, so this activation, right? So for the platelets to go and adhesion or like to stick to the membrane and also get together to aggregate, the platelets has to be activated, right? So we call it platelet activation. So for that to happen, certain things has to happen, and it should interact with the platelets, right? So there are three types of things, right? First one is things that is uh, synthesized outside, like something like that. So can you give one example for that? And they will interact with the receptors on the platelet membrane, and they can activate the platelet to go through this process, adhesions and aggregation. Can you name one such compound or substance?
Collagen.
Collagen, right? Collagen, thrombin. So there are certain things. So they can go and bind to this, and then they will activate the platelets. And there's another type which are produced inside the platelet, right? And then, but they will also interact with the membrane receptors. They produced and they come outside, and then they will interact with the receptors, right? So can you give an example for that? Can someone give examples for that? Hmm? Can someone give an example? Hmm? Can you all see now? Can you give an example for the second type?
Prostaglandin.
You have to be specific. Prostaglandin D2 and E2, and also A2. So those are the things that will produce inside and then interact with the membrane receptors. And what is the third type? Third type is they will interact, generate or produced inside and interact within the platelet. So it will not go outside or interact with the receptors, membrane receptors, but this will be produced and they will also interact internally. So this is produced internally and also interact internally. So what are those? One example. Can someone give an example for the third type?
Prostaglandin endoperoxidase.
Yeah, prostaglandin endoperoxidase, which is an enzyme, CAMP, CGMP, calcium, so those things are generated inside, also act internally. And by reacting or like by the action of them, they can also activate the platelets, right? So if we like again summarize, when there is a damage in the blood vessels, the platelets will go and bind to the endothelial tissues. That is known as platelet. What? What we call that?
Adhesion.
Adhesion.
And also, they will also stimulate the other platelets and they get together, which is known as the platelet
Aggregation.
aggregation. So for these things to happen, platelets activation has to happen. So this activation will happen due to three types of agents, due to the interaction of three types of agents or compounds or substance or whatever. One is things that are generated or produced outside of the platelet, but they can come and interact with the platelet receptor membranes and then activate the platelet. For example, collagen. Collagen is like actually the breakdown, collagen will be produced by the breakdown of this blood vessel wall, right? So they can come and interact and activate. And there are some agents which are produced inside the platelet and they act on the membrane receptors as well, but they are produced internally. For example, ADP, prostaglandin D2, prostaglandin E2. So those are the types of agents that are produced internally and active in membrane receptors interaction. And third type is which are generated or produced internally, but they will also interact internally. They will not react with the receptors, but they interact internally and they will activate the platelets. So examples are CAMP, calcium, prostaglandin endoperoxidase, so those type of agents, right? Is it clear now?
Yes, miss. Yes, miss.
Right? So the net effect of platelet activation and aggregation is the promotion of further activation and formation of a physical barrier at the site of injury. So the net effect of platelet activation and aggregation is the promotion of further activation and formation of physical barrier at the site of injury. Right? So, as we discussed earlier, today we are going to talk about antiplatelets. One second. Okay, so antiplatelets drugs are used to modify the coagulation cascade for the regulation of for the regulation of coagulation and for the treatment prevention of bleeding. Okay, so first one is aspirin, which is also known as acetyl salicylic acid. Thromboxane A2 in platelets. One second. Message දාලා platelet aggregation among other activities like vasoconstriction. Inhibition of this process inhibit platelet aggregation, prolonging the bleeding time, right? So aspirin inhibits thromboxane A2 production by irreversible acetylation of platelet cyclooxygenase 1 or COX-1 because the platelets cannot make new cyclooxygenase during the 10-day lifespan of the platelet. Repeated doses of aspirin has an ongoing effect. Irreversible inactivation of platelet COX-1 can be achieved by a 75 milligram dose of aspirin, and higher doses are reversible inhibitors of COX-1 and does not have antithrombotic functions, right? So if we summarize this thing, so aspirin, acetyl salicylic acid, we know this drug as a Which type of a drug? General aspirin. Yeah, analgesics basically. It is analgesic drug, which means it will reduce the pain, right? It will use to reduce the pain or a painkiller. So that is the major action of aspirin. But at low doses, aspirin has antiplatelet activity as well, right? So it is 75 milligrams. So no, what is the normal dose for analgesic effect of aspirin? What is
75.
the,
75 milligram.
who said 75? Was it Sharmila? So others? So Sharmila says 75. Who is in iPhone? Is it Niroshini?
No, Miss, I am
What is your name?
Sharmila.
Sharmila. So Sharmila, you said 75. So others? What is the analgesic dose of aspirin? 300 milligram. Shamila, told you like 75 milligram is antiplatelet dose. So which is a low dose, right? So aspirin analgesic dose or the pain killing, we need to use 300 milligrams, right? So at that point, we can't achieve antiplatelet activity. We will discuss this. At that dose, antiplatelet activity is not there. Why? Uh, so, right? How it happens is, we know, so you have to refer again this, this process we discussed in under NSAIDs from arachidonic acids. There will be different things formed. One is thromboxane, some other prostaglandins, plus different types of prostaglandins like prostaglandin E, G. Likewise, there are different prostaglandins, and also thromboxane is produced by the involvement of COX enzyme. So what is COX? What is the longer version of COX?
Cyclooxygenase.
Cyclooxygenase enzyme. So there are COX-1 and COX-2 enzymes. So COX-2 enzyme is mainly responsible for prostaglandin synthesis. So COX-1 is mainly thromboxane as well as some prostaglandins, right? So what aspirin does is it inhibits the COX-1. So when it inhibits COX-1, thromboxane A2 production will be inhibited, right? So thromboxane A2 production will be inhibited, and so this is inhibited. Therefore, platelet aggregation also will not happen. I mean, from other means it will happen, but it is drastically, platelet aggregation will also go down, right? So they inhibit this cyclooxygenase 1 is in the platelets, In the platelets also, this enzyme is present, right? COX-1. So, why we can't achieve at higher doses is when we give a low dose, at low doses, low dose, irreversibly inhibit. This COX-1 will be irreversibly inhibited. So to produce new COX enzymes to the platelets, it will take like 8 to 10 days, right? So if we repeatedly use this 75 milligrams, so we can achieve a long-term effect of antiplatelet or aggregation or whatever antiplatelet activity can be achieved, right? Because it will take around 10 days to produce new COX enzyme, because when it is bound irreversibly, that COX enzyme cannot be used again, right? If it is reversible, okay, when it is detached, the COX enzyme can be used. But irreversible meaning you can't reverse it. When aspirin molecule is bound to COX enzyme, it is there forever. So it will take 10 days to produce new COX enzyme, right? But at high doses, this becomes reversible. This inhibition is reversible when you give high doses, like the analgesic dose 300 milligram. So at that level, we can't achieve a antiplatelet activity. And also, if you want to achieve if you want antiplatelet activity, and it can be achieved by 75 milligram, we don't have to give more as well, right? For example, if there is a patient who is a risk patient for cardiac diseases or something like that, so we don't need to give 300 milligrams if he doesn't have any pain, right? So we don't want to manage the pain because he doesn't have any pain. We want the antiplatelet activity. So if we can achieve it by 75 milligram, so why we should give more? The other thing is when we give more higher doses, the antiplatelet activity will not be there as effective as the low dose, right? Therefore, we use 75 milligrams. So is that clear? Is that clear to you? Why we need to use a low dose?
Yes, miss.
Okay. Others? Miroshini? Or can someone explain? Can someone explain to me why we should use a low dose of aspirin for antiplatelet activity? Niroshini? Jaga, Janani, or Shamila? I want one of you to explain it. Is Chaga there? Janani, Shamila, Niroshini? Can one of you explain it to me? Okay, can one of you say what is the dose of antiplatelet action for aspirin?
75 milligrams.
Yes, 75 milligram. So that is a lesser amount than what we usually use for aspirin. Like for aspirin, for analgesic effect, we use 300 milligram. So we use 75 milligram. Why we should use a low dose? Or else, can someone explain the mechanism of action of aspirin with regard to the antiplatelet activity? I want someone from the names that I mentioned, like Chaga, Sharmila, Niroshini, and Janani. What is the mechanism of action of aspirin for antiplatelet activity? Do you understand it, or like if you don't understand, tell me, I will explain again. Right? Niroshini, are you there? Niroshini is there, right? No, she is not there. I don't know. Hmm. No one understood. Is that what I should take?
Inhibit COX-1 enzyme. Antiplated dose of aspirin inhibit COX-1 enzyme.
Pardon me, can you say it again? Janani, can you say that again?
Antiplated dose of aspirin is inhibit COX-1 enzyme.
COX-1 enzyme, irreversible, right? So that is the difference. Can you explain again? So if you don't understand Chaga, you have to say that before I ask you a question, right? When I ask you a question, you can't say explain again, but I will explain again. But after I explain, I will ask you the same thing again. You have to tell me, okay? Okay. So acetyl salicylic acid or aspirin is generally a analgesic drug, which means a drug that we use for reducing pain or a painkiller, right? So for the analgesic effect, we use 300 milligrams of aspirin, right? But at low doses, aspirin also shows an antiplatelet activity, right? So antiplatelet activity is showed at a very low dose, for example, 75 milligram, right? 75 milligram compared to 300 milligram, 75 milligram is a low dose of aspirin, right? So by giving 75 milligram, we can't achieve analgesic effect or pain killing. So if there is a patient with pain, we can't give him 75 milligram, right? But anyway, aspirin is not very much used for analgesic effect also nowadays because of the side effects. But anyway, for antiplatelet activity, we have to use a low dose, right? So aspirin's mechanism of action, even for analgesic action, for antiplatelet, so anything, is inhibiting COX enzyme. It inhibits COX enzyme, so especially COX-1. So COX-1 is an enzyme which is responsible for production of thromboxane A2 and some prostaglandins as well, right? So thromboxane A2 is important to platelet aggregation, right? So when we inhibit the thromboxane A2, so when COX enzyme is inhibited, thromboxane A2 will be inhibited, right? If I explain again, COX-1 enzyme will produce thromboxane A2, or COX-1 enzyme is important and required to produce thromboxane A2. When COX-1 is inhibited, thromboxane A2 will not be produced, right? So thromboxane A2 is not there, platelet aggregation also will get inhibited, right? Because thromboxane A2 is needed for the platelet aggregation, right? Is that clear up to that? Is it clear now? Chaga? Up to now, is it clear? Chaga, can you talk? Is it clear up to now, Chaga? I'm asking you. I'm taking time out of others also and explaining again if you are not Are you not here, or like, at least you can send a message, no chat. Is it clear, Chaga, to you?
Yes, miss.
Okay. So now, from arachidonic acid, thromboxane is formed. So in the process, COX-1 is an enzyme. So COX-1 is inhibited by aspirin anyway, aspirin will inhibit COX-1. So thromboxane will not produced, and thromboxane A2 is not there, aggregation also will get inhibited, right? So what is the difference of low dose and high doses? At low doses, this inhibition of COX-1 is irreversible, right? Irreversible. Therefore, until the platelet generates new COX enzymes after 10 days, like 8 to 10 days, antiplatelet activity will be there, right? At low doses, irreversible inhibition of COX-1 is happening. But at high doses, the inhibition is reversible. Therefore, we can't see an antiplatelet activity, right? So that is the whole picture. So can you, Shaga, now explain a little bit out of what I have explained now? That is, what is the mechanism of action of aspirin with related to the antiplatelet activity? Can you explain now? Shaga, are you there? Shaga. So so you said now it's clear. So can you tell that again back to me? Can you explain it again? The mechanism of action of aspirin with related to antiplatelet action. Chaga, I want something from you, some answer, something. Chaga, you have to say something at least.
For the conversion of arachidonic
Arachidonic acid.
acid to thromboxane A2.
Okay.
Low dose inhibit COX-1 irreversible, high dose reversible.
Okay. So at low doses, therefore, we can achieve the antiplatelet activity. Okay, very good, Shamila. So,
Thank you, miss.
okay. So, because irreversible inhibition, new cyclooxygenase will generate around 10 days after 10 days, because um, platelet has a 10-day lifespan, right? So the new platelets and new cyclooxygenase will produced after 10 days, right? Mm. So irreversible inactivation of platelet COX-1 can be achieved by this one. We have talked about high doses are no more efficacious and may increase toxicity, especially gastric bleeding. Right? Mm.
In case of stroke or something, they used to give a stat dose 300 milligram aspirin, no?
Pardon me, Sarah?
In case of stroke, trans ischemic attack or stroke,
No,
uh,
it's not clear to me. What is the indication? Stroke.
stroke
Post
or ischemic attack.
ischemic heart attacks. Oh, okay.
300
In heart
milligram
attack.
stat dose.
So 300 milligram is given. Is that what
Yeah, yeah, stat dose is given.
let's check. Mm. That is given as a loading dose.
Yes,
So that is the case. Okay. So even patients with diabetes, if they didn't have attack or a stroke, also they are given 75 milligram because to reduce the risk of getting these ischemic heart diseases and
yeah,
the coagulations, right? Other cyclooxygenase inhibitors like other salicylates and other non-steroidal anti-inflammatory drugs are reversible inhibitors of COX-1 and does not have antithrombotic function, right? So they are reversible. So we discussed what is the difference between reversible and irreversible. So therefore, they can't achieve a good antiplatelet activity or antithrombotic activity or function. So clinical uses of the aspirin after coronary bypass surgery, arterial fibrillation, intermittent claudication, stable angina after placement of stents following a stroke, and after effects, increased gastrointestinal bleeding, increased frequency of peptic ulcers, allergic skin reactions, tinnitus, contraindications, active peptic ulcerations, children below 16 years, because of they can get race syndrome, and hemophilia. If the patient has hemophilia, anyway, we will not give any anticoagulant or antiplatelet drug, right? And the next drug is ticlopidine. Ticlopidine is a thienopyridine product, so you don't have to know all these details. So they will inhibit a P2Y12 receptor on the platelet. So P2Y12 is a type of receptor which is present on the surface, membrane surface of the platelet. And these are the receptors which will bind with some compounds and get the platelets activated, right? So this P2Y12 receptor on the platelet resulting in lower levels of cyclic AMP. So when the receptor is inhibited, the cyclic AMP level will go down. So cyclic AMP is needed for platelet activation because CMP, cyclic AMP is like giving energy as well. And also this is important in platelet activation process as well. So when P2Y12 receptor is blocked or inhibited, cyclic AMP level will go down. Therefore, platelet activation will also go down. So ticlopidine is converted to the active drug of active drug by hepatic cytochrome P metabolism. It is rapidly absorbed and permanently inhibited by the P2Y12 receptor, but the maximal inhibition of platelet aggregation is not less than 8 to 10 days later. Continued inhibition of platelet aggregation is seen for a few days after the drug is stopped as well, right? So, can someone explain me what happens with ticlopidine? So, ticlopidine is a prodrug. So, what is a prodrug? Can someone tell me what is a prodrug?
The drug is in an inactive form. When it goes through the liver for the first time, it gets converted into its active form.
Okay. Answer is almost correct, but there are few words missing. First one is
Administered form.
administered form. So that is very important. Okay, so the administered form is inactive, and when it is metabolized in the liver, it will convert to the active form, right? So, what is the mechanism?
Irreversible action.
Irreversible inhibition of what?
7.
Inhibit P2Y12 receptor.
Yeah, irreversible inhibition of irreversible inhibition of what? Sarah, can you tell that again?
I didn't tell miss. Inhibition of P2Y12 receptor
Okay, where is the P2Y12 receptor situated?
in the platelets.
Platelets, right? So the ticlopidine will inhibit the P2Y12 receptor, and by inhibiting that, what will happen?
Cyclic AMP level will go down.
Okay, cyclic AMP level will go down. So cyclic AMP, when the level is go down, how it affect and why?
That activation will be reduced.
Reduced, because for the activation, the body needs cyclic AMP, right? For the activation of platelets, there are different compounds which are needed. So CMP is also one of the major compound which is required. So when the level is go down, the activation will also go down. Since it is irreversible, platelet aggregation will not see until 8 to 10 days until the new platelets are formed, right? Is that clear? So somebody else can say that again. Jayani? Can't hear Jayani. Can you speak little louder? Mhm. Okay. I didn't clearly hear what you said, but I think you said the correct answer. Okay. So if I repeat, ticlopidine will inhibit the P2 Y12 receptor on the platelets. So this receptor inhibition will cause the low level of CMP. CMP is required for platelet activation. So when the CMP is less or low, the activation is also will not happen or will be very less, right? So adverse effects, nausea, vomiting, diarrhea, serious neutropenia, fatal granulocytosis with thrombopenia. Therefore, blood monitoring for the first few months is required, and rarely thrombocytopenia, where the platelet counts should be monitored for that, so that can happen. Because of the incidence of life-threatening blood dyscrasiasis, it is not used as much and is now replaced with clopidogrel. So these are the adverse effects, and uh, they have like life-threatening, serious side effects are there, like neutropenia is also a serious one, and thrombocytopenia, though it is rare, it is also possible, and also this blood dyscrasiasis, which is a life-threatening condition. Therefore, nowadays, ticlopidine is not much used, and instead of that, they use clopidogrel. So before going to clopidogrel, so I want you all to summarize what we have learned up to now, right? Summarize it, and aspirin, go through aspirin and write the mechanism, and also I think contraindications are also there, but please check with the BNF. And if there is new thing, please include. And also these conditions. Clinical uses. Uh, if you don't know any, some terms, we are not very familiar with this, right? What is race syndrome? What is what is thrombocytopenia? What is neutropenia? If you don't know, like, get to know what is thrombopenia, right? What is agranulocytosis? So that is a fatal condition. So that can also happen. So get familiar with the terms, and clopidogrel contraindications, sorry, ticlopidine contraindications and the doses as well for ticlopidine and dosage forms. Right? Are you all clear? Summarize the first part is you have to write the drug name and the mechanism of action. Clinical uses are and side effects. There are some terms we are not very familiar with. So get familiar, get the meaning of the term. And for ticlopidine, write the contraindication and doses as well. Is that clear to you all?
Yes, miss.
Yes.
Okay. Okay.
Miss, one thing about aspirin, it's
Mhm.
irreversible, right? The side COX-1 inhibition is irreversible, right? At 75 milligrams.
Yes, at low
Uh,
doses, it is reversible. Yes.
okay, but at higher doses, it becomes reversible.
Yes.
Is- Oh, okay. Because
Because
I was
maybe,
confused.
no, you
Huh?
think how it
Sorry.
happens, is it? Is that what you have?
No, I was confused about this part in the tube. I just put it in the
No,
chat.
because it is reversible because there are a lot of aspirin molecules, right? So at that point, maybe, I don't know, maybe it is not clearly found or discovered up to now what happens really. But maybe we can think when there is another molecule, like these molecules can compete each other, and there's a tendency of the molecule that is also already attached, can detach from the receptor and others can bind, something like that. So then it becomes reversible. But when there are low doses, they go and bind, and that will become a permanent binding, right? So that is what we can assume what happens, right? So since when it is irreversible, COX-1 enzyme can be free sometime, right? Because if the molecule is aspirin is detached, now COX-1 is not inhibited. So they can work. But when it is irreversible, what happens? It is permanently blocking the COX-1. And within the lifespan of the platelets, which is 10 days, they cannot produce COX-1 is enzyme. So it is a protein. So they can't produce or make new COX-1 within that lifetime, right? So they will die after 10 days. So therefore, the platelet aggregation is stopped for that platelet for its lifetime. So when the new platelets are generated, then they can have COX-1 and aggregate. But if we giving continuously this low dose, we can achieve a platelet inactivation for like certain period of time, prolonging time. Right? Is it clear now, Namindu?
Yes, Miss. If you can look at the chat, I pasted that part.
Yeah. Just now only I saw it. Irreversible
Okay.
inactivation of platelet COX-1 can be achieved by a 75 milligram dose of aspirin, and higher doses are no more efficacious and may increase toxicity, especially gastric. Yes, that is also I explained, right? During my explanation, I said two reasons why we use a low dose. One is if we can achieve the antiplatelet activity by 75 milligrams, why we are giving 300 milligrams? Because giving 300 milligrams is like the cost, and also we are getting more side effects. Getting more substance means we get more side effects, right? If we can reduce the dose, side effects can be reduced as well. And we can't achieve more effect also by increasing the dose. And also by increasing, we don't get antiplatelet activity, right? Since it is reversible, there is antiplatelet activity, but it is not as the 75 milligrams, right? Do
Oh,
you get what I'm saying?
yeah, Miss. Thank you.
Okay.